Sleepless in Halifax, a discussion on awake intubation with Ian Morris. Now, I've had the great fortune of being able to hang out with these two handsome individuals. On the left is Dr. Adam Law, who's an anesthetist and co-developer of AIM, and on the right is Dr. Ian Morris, who's an anesthetist and also trained in emergency medicine. Now, when I was a resident, the Rosen chapter on airway management was by Ian Morris. Now, these two fine gentlemen have a great deal of experience in awake intubation. This is a nice representation of this. This is a paper that they published reviewing over 1,500 awake tracheal intubations done here in Halifax over a 12-year period. And it's a great read, but two of the findings that I think are important to point out. One is that over this period of 12 years, awake intubation remains a predominant procedure that is done for patients with the anticipated difficult airway. And the incidence and its use hasn't decreased despite the increased use of video laryngoscopy. What's also quite remarkable is that with these 1,500 patients, over 1,500 patients, their first pass success rate is over 93%. Pretty impressive, to say the least. Now, as I said, Ian was the author of Rosen's chapter on airway management when I was a resident. But more recently, Ian is recognized in the anesthesia world for his expertise in awake intubation. He was the author of the chapter on preparation for awake intubation in Hung and Murphy's book on difficult and failed airway. And Ian was good enough to let me read a copy of his revised edition of this chapter, which is going to be released by the end of 2017. And it's an impressive read. I don't think there's any other document out there that's as thorough in examining the issue of awake intubation as this chapter is. Over 345 references. And again, he leaves it up to the reader to decide what their approach is, but it's I think, an incredibly important read. Now, I know some emerge people and critical care people might say, well, how is this relevant to our environment? Well, I think it's incredibly important. We look to anesthesia for its skill in airway management, and we still are occasional intubators, and it's important for us to appreciate the expertise of our colleagues and then figure out how we're going to modify and adapt it to our environment. So I do appreciate the fact that much of this interview, you might say, okay, how is this going to apply to our patient population? Well, in a subsequent post, I'll talk about this in a bit more detail, but all of these basics are easily applied to our environment, and they are the core ingredients of a successful awake intubation, regardless of your environment, at least in the emergency department, and I think in the critical care environment. And it's proven to be an incredible resource for me. So let's get on with it. All right, George Kovac here. Just to show you how dedicated I am to getting this post right on awake intubation, we're going to travel to see one of the world's experts on awake intubation, Dr. Ian Morris. Here we are. I've traveled to visit Ian from my house, 3 doors down. Let's see what he has to say. After an exhausting trip to get to Ian's place 3 doors down, I began our conversation by asking him how long it takes to topicalize and ultimately intubate a patient awake.
Then I do the local anesthetic technique. Takes about 5 or 6 minutes, 6-7 minutes. And then routinely it takes about 30 seconds to do the intubation. So my technique is to have all my equipment and all my local anesthetic is prepared before I start to work with the patient. The patient routinely gets intramuscular glycopyrrolate 30 minutes before I plan to do, and these are primarily elective or urgent awake intubations, because 30 minutes gives you really good drying of the mucosa. So then, once the IV is in, I start...
Let me stop you there for a second.
Yep.
When you say drying, and again, I don't have this experience, what would be the difference in terms of what you would see in somebody who's been given, glycopyrrolate versus somebody who's not when you're looking in their mouth?
Well, when you look in the mouth of somebody who's not had an antisialagogue, the tongue is glistening, it's reflecting light, and it looks wet. Once you've had a drying agent, your tongue looks a bit like a rag, it just doesn't reflect light, and the tongue looks clearly dry when you look at the tongue. And in fact, if the tongue is not dry, then I will wait 5 minutes for that drying to occur. So again, I need 30 minutes from an intramuscular shot of glycopyrrolate, and the literature says 15 minutes from an IV shot. I don't have much experience with that, only a few cases, and it certainly seems to take at least 15 minutes.
But to be clear though, it's not going to dry up the person with pathologic secretions from a pneumonia or
so
other
it
things.
will help, but you're quite right. If you have some stimulus going on that's making you very wet, then the glycopyrrolate won't make you that dry. It'll help some, but it won't make you that dry.
Okay. All right, so carry on.
Okay, so step one with the local anesthetic then is to put lidocaine ointment on the posterior third of the tongue, right? So the posterior third of the tongue is innervated by the glossopharyngeal nerve, the anterior 2/3 is by the trigeminal nerve. So the gag reflex is the posterior third of the tongue. And in my experience over the last 30 years, that is the most difficult structure to anesthetize. Lidocaine ointment is magic. The viscous doesn't work, the solution doesn't work, gargling doesn't work, but paste or ointment, the 5% that we have in Canada, is like magic. It stays roughly where you apply it. I put a bit on the end of a tongue depressor about the size of my thumbnail, about 1 millimeter thick, and I lay that just behind the sulcus terminalis on the tongue, let it start to melt, and then slowly move, say, from the left side to the midline to the right. If the patient is tolerating it well, I'll go back 1/2 centimeter, and then go from the right to the midline to the left. And it takes about a minute or maybe 1.5 minutes to apply that. I try not to smear it over the tongue or to press on the tongue in case I initiate pressure to receptors right located in the tongue or alleged to be at the tongue.
Yeah, Ian's referred to it as magic, and I have to agree with my experience, which is much less than Ian's, obviously. But it is magic, and again, I think it's something that you can't omit. I know our friends south of the border, it's not so easy to get, but we have called pharmacies in the US, and it is available, but at great cost. And I guess one of the difficulties in the US is you get a big tube or jar, they're not allowed to sort of reuse it, so we have a tube that we can reuse on a tongue depressor, whereas a lot of hospitals will not allow that. And I actually found that you can buy it in large jars. It actually comes in a flavored version, but these large jars are as much as $500-600 American. So, but to tell you the truth, it's just such an important agent that it's worth finding a resource to have that. The other thing that I've done is that it's nice if the patient can open up their mouth and stick out their tongue, but if they're unable to do that, having a colleague or somebody there trapping the tongue, so they stick out the tongue and you put a gauze on it and hold it out there, that's often helpful.
Yep, absolutely. And the point about I know Astra sells it in the United States. The tubes that we use are about the size of a travel toothpaste tube, probably 30 grams, something like that, maybe 15 grams, they're pretty small. But again, there is nothing else that will anesthetize the posterior third of the tongue, so well worth, I think, the investment, right? So that's step one. Right?
Yeah, and how much volume do you think we're using? So we're estimating it's a glob, it's about 1 centimeter there, so I think we were talking about this the other day, it's probably no more than 2 cc's or 2.5 cc's
max,
probably.
Yeah, I would say even less than that. It's It's difficult to measure, but
Okay.
yeah.
So let's say if we were at 2 cc's there, then or less than 2, so we're looking at we're at a about 75 to 100 milligrams of again agent being used here. We'll get to that later, but
Okay. So then step 2 is to deliver atomized local anesthetic. And we currently are using the Alcove atomizer from Houston, Texas, Alcove Medical Corporation. It's a disposable device that costs about $20 for each, utilization. It is, I think, again, unsurpassed in the equipment that I've used to deliver atomized local anesthetic. And there's a big distinction between atomized and nebulized, right? So nebulizers were designed to deliver droplet sizes of 1 to 5 microns to deliver Burkinel, Ventanil, and such drugs deep into the tracheobronchial tree. What we want is big droplets, and ideally droplets in excess of 40 microns to rain out in the proximal airway. I can't tell you what percentage of the droplets are above 40 microns with the atomizer, but I can tell you it's way better than with the nebulizers. The amount of local anesthetic deposited on the mucosa is a function not only of droplet size, but the angle at which the spray hits the mucosa, the velocity, the turbulence, and the physics of atomization are complex. But anyway, I deliver it with the atomizer. I put 30 cc's in the atomizer because it gives a nice balance, makes it easy to hold, and I deliver about 10 cc's of 4% lidocaine. Now, if I'm concerned about somebody's low body weight, or if somebody's got liver disease, for example, I might cut it to 3%, but I would never go below 3%.
and the 3% is done by mixing a combination of 2%
With water.
yeah.
Or you can mix
do the
4% and 2%, or
or
you can just
just-
take 4%
and dilute it.
and dilute it with water.
right. Okay.
So
Yeah,
am
just the alcove. It comes in 2 sizes. One's a 15 cc container. I think the other one is a 50 cc
50, yeah.
container, and then you hook it up to flow whatever you want, whether it's oxygen or air, and use a flow rate of
8 liters a minute. And again, by trial and error over the years, 8 liters per minute seems to be the best delivery rate. And when I've talked to one of the RTs about that, they say that in fact 8 is the ideal flow rate for most nebulizers as well. But anyway, 8 seems to work well. I deliver it through the nose, even though I'm going to intubate through the mouth, because remember, your natural airway is through your nose. And I have people sniff. So when you sniff in, as you breathe in or sniff in, I'll deliver the atomized anesthetic over that inspiratory phase. It seems like if you keep delivering it beyond the end of the inspiratory phase, you can precipitate cough. I have no idea why that occurs, but it can occur. So I deliver it when they inspire, they breathe out through their mouth, let them breathe in and out. Do that about 3 or 4 breaths, give them a break. Do another 3 or 4 breaths, give them a break. Do another 3 or 4 breaths, give them a break. And by that time, you've used about 8 cc's of the 4%. Because I've only put paste on the tongue, I'll deliver the last bit through the mouth, and I'll aim it right at the uvula and the tonsillar pillars to make sure that I've anesthetized those areas.
So
Now,
going through the nose, though, our primary target is to
It's the pharynx,
administer.
larynx, and trachea, right?
Right.
So we could care less about the nose, but it delivers it very efficiently to the pharynx, the larynx, and the trachea. Now, after those 2 steps, you have a very adequate block almost all the time. But if you want to be absolutely certain that you have no reactivity in the larynx, then you could do an internal approach superior laryngeal nerve block, which is what I do routinely with Jackson forceps, which are designed to hold a pledget soaked in 4% lidocaine. So I take a pledget, I soak it in 4%, I lift it up. If it's dripping, local anesthetic, just wring it out so it's wet but not dripping. Introduce it over the back of the tongue, stay close to the midline until you get into the vallecula, and then lateral caudad, lateral again to get into the piriform sinus. And even patients with big obese necks, if you put your hand on the side of the neck just lateral to the thyroid cartilage, you'll feel the pledget push it against your fingers. I have a technician time me for 60 seconds, get a new pledget, I'll do the other side, and when you finish that, you have a completely anesthetized upper airway, right?
And I guess that also gives you a sense when you're applying it of, you know, how well you've done so far in
Yep.
terms of your ability to tolerate that.
Yep. Now, you can also use those supralaryngeal nerve blocks in patients where, for whatever reason, you haven't been able to get enough delivery of the atomized anesthetic. So paste on the tongue will allow you to get past the back of the tongue, and then you can sometimes go straight to the forceps on either side to get the larynx.
Right.
You won't have the trachea, and then if you go with that technique, you may have to inject some, into the trachea or use your atomizer to get into the trachea. But that's where patients are not as cooperative.
Right. So we've talked about now, we've delivered, a wad of 5% ointment. We've delivered up to 10 cc's of 4% lidocaine. In your situation, we've delivered 2 pledgets that were soaked but ringed out on each side to do your block. How much volume do you think we have collectively used? Do you think in general it's over 5 or 4 or 5 cc's per kilo on an average patient?
You mean milligrams per kilo?
Yeah, I'm sure that's right.
I'm not sure, because of the 10 cc's atomized that you deliver, the patient doesn't get all of that atomized amount. Now, what percentage should you calculate? Who knows, right? But in the literature, many will say that 50% of what you have delivered by atomized technique is actually exhaled again, right? So that is not absorbed. Now, I suspect that the ointment will give you a lot of absorption, and I think the ointment should be only put on the posterior third of the tongue. I would not put that in the piriform sinus, for example, because I suspect uptake will be tremendous. Most of the blood level that you get with that technique, I suspect, is from the pledgets in the piriform sinus, because it's been shown that absorption from the piriform sinus approximates IV injection, right? But again, to try to weigh a pledget, and then it gets some saliva on it, so when you take it out, it's the pledget with the local some gone into the patient, but there's saliva, and there's no way to calculate it, right? I do think, George, that we are well under 8 milligrams per kilo. Now, there's at least 30 articles that use a number of different techniques and a number of different milligram per kilo dosages and measure blood levels after that, right? And trying to compare studies is almost impossible because the techniques are so variable. It can be said that, many investigators have used more than 8 milligrams per kilo, up to 14 milligrams per kilo, and one investigator up to 19 milligrams per kilo, although they deliver that over about 45 minutes. So I think, 8 milligrams per kilo is a very reasonable dose not to exceed. And in fact, the British Thoracic Society in 2001 recommended that that dose not be exceeded in bronchoscopy. They didn't detail what technique you would use. But I think 4 milligrams is excessive. 4 milligrams per kilo is excessively conservative, and it's not based on any data. George, interestingly, about toxicity, when I tried to look up all the seizures that had been reported in the literature related to lidocaine, and in fact all of them had either had viscous, 2% viscous in their airways, or had solution. So they all had solution injected, not spray, just injected, or applied to the mucosa, or viscous, right? So I suspect you do get more absorption, particularly if the viscous goes into the piriform sinus.
And again, one of the concerns is it's a risk benefit. So what's the risk of toxicity, based on these doses versus the risk of inadequately anesthetizing the airway?
Right. So I can tell you that with that basic technique, multiple operators in our institution have been performing awake intubations for close to 30 years now, and to my knowledge, we've had no toxic reactions whatsoever. Now, the 2 papers to refer to, I think, is the one by, I think it's Vizoric, the pronunciation from Montreal, and they delivered up to 1,600 milligrams, 40 cc's of 4% lidocaine with an atomizer. And they measured blood levels, I think at the highest were 6 point something, but most of them were lower than that. And 16 milligrams is a huge dose. I mean, I would never consider going to that dose. In the 800 milligram group, right, they had nobody, as I recall, nobody above the toxic level, mostly in the 3 point something.
What is the
range.
toxic level?
Toxic level is 5 mics per cc, and they were mostly 3 mics per cc after 800 milligrams, right? So, I think you're way below the toxic level with those doses.
So I think that's one of the major messages that I wanted to really get out there. I know that there's been some description of people recommending as low a dose as 1%.
Yeah, so that's curious. So Dr. Adriani, back in the 1960s, looked at the maximum effective concentration of topical local anesthetics, and he determined that 4% was the maximum effective concentration of lidocaine. As your percentage gets less than that, then you get less effective block, right? Now, Ovasapien, in his 2001 review, says that 1% is not adequate for instrumentation of the airway, and I couldn't agree with him more. I think it is inadequate, and Ovasapien had a tremendous experience with many, many years and many, many, intubations. So I think you had to give him a lot of credit for that. Now, he did reference Dr. Adriani's 64 paper when he made that statement. And when I went back and rechecked the 64 paper, I couldn't find that fact, right? There was a lot of other facts there, but I couldn't find that exact fact. Now, more recently, in that same group from Montreal, Dr. Woodruff and his group, instead of doing 4% and 2%, again randomized patients to either 2% or 1%. Again, delivered by atomizer. They were using the Sleepless atomizer. And they quite clearly showed that the 1% was not adequate for airway instrumentation. In fact, they stopped the study early because it was obvious that people were not getting an adequate block. Okay. Similarly, in the Zurich's paper, right, when they randomized patients to 4% and 2%, they said that 2% was adequate, but one of the 13 in the 2% group, quotes, could not tolerate the intubation. I think in awake intubations, you can't afford to have a 10% failure rate.
All right, so that was a great overview by Ian, and thank you for participating in this discussion. Just to summarize again, the ingredients that Ian uses and that we use in our emergency department, we use a high concentration 5% lidocaine ointment that's applied with a tongue depressor to the posterior aspect of the tongue, and then using an atomizer, applying 4% lidocaine to topicalize the remainder of the airway, and using these agents in combination will give you a successful or great conditions for doing an awake intubation. Now, a lot of people again might be weary and saying, okay, how do we do this in the patient that we're faced with in the emergency department in the critical care setting? And I used to believe that awakes were rarely feasible in the ED, but this has not been the case in my experience, and I really do feel that it's almost a rare scenario that I don't feel I could do an awake approach on a patient. This is a picture snap from a patient I did an awake intubation on, who had a penetrating neck injury. Again, just to show you sort of an extreme version where we might have said that, usually these patients aren't so cooperative. They often are. And patients presenting in respiratory failure, again, they might not be cooperative and awake in the usual manner, but we can usually talk to them, topicalize them, and sparingly use a sedative or a dissociative agent such as ketamine to sort of facilitate the awake intubation. But I want to be clear, and I'm going to talk about this more on a separate post when I talk about the awake in the ED specifically, that the use of ketamine or other sedatives shouldn't be a shortcut for applying appropriate amounts of a topical agent. That's what gets you buy-in and success. So again, thank you to Ian and Adam for sharing their expertise over time, and there'll be a follow-up detailed post discussing the awake intubation and pearls in the ED coming up soon. Thanks.